See this?
Yes, sir, we can see your presentation.
Okay, I'll start. So, my name's Saqib Iqbal. I'm one of the junior doctors in the UK, who has a special interest in neurology, and I've done some research, a case-based study on Behçet's disease, looking at the neurological perspective and which unravels the clinical and systemic manifestations of this condition. Um, so, just a bit about the history of Behçet's disease. Um, it was first described by his, um, who documented oral ulcers, genital sores, and eye inflammation in groups of patients. And in terms of any modern recognition, um, a gentleman called Dr. Hulusi Behçet further took this on board in 1937, who noted a triad of recurrent oral ulcers, genital ulcers, and uveitis. Um, his work wasn't officially recognized until 1947, where he presented in the International Congress of Geneva. And then ever since, there's been continued research on this matter, looking at the triad of what we mentioned before in terms of the three conditions on top of neurological, vascular, and the gastrointestinal involvement. But there is a strong factor of epidemiology in this, in terms of where this affects the most, and it's known to affect the East and the West, known as the Silk Route, in terms of the patients. We'll look at the introduction of Behçet's. So, Behçet's in itself is an autoinflammatory vasculitis which affects arteries and the veins in all sizes. So, it's not specific to a medium or a small size. It affects all of the arteries and veins inside the body. It lacks specific autoantibodies, and it's characterized by cell-mediated immunity in its pathogenesis. Um, so, in terms of the pathophysiology, the way that it's activated, it's through T helper 1 cells, which drives the systemic symptoms. It's elevated pro-inflammatory cytokines such as interleukin 1 to 17 and tumor necrosis factor alpha, which contributes in the progression of the disease. Any neutrophil overactivation can cause vascular injury, leading to mucocutaneous lesions. And it follows a more severe course in males and younger individuals compared to females. So we look at some of the risk factors of Behçet's disease. So the exact cause is unknown. However, there have been theories as to who can be affected by this, whereas there's genetic and environmental factors that are believed to contribute in this condition. As mentioned before, it's an autoinflammatory vasculitis without any necrotizing vasculitis or formation of giant cell, etc. The strongest genetic link has been linked with HLA, B51, and B5. It's also hypersensitive to certain bacteria such as Streptococcus sanguinis antigens, and it's tend to be more severe. Like, it's one thing that we found out, that it's more severe in males compared to females. So we'll talk a bit about the clinical case that we came across as a patient. So there was a 17-year-old male presenting with a history of recurrent painful ulcers, which healed without scarring. And he also reported of painful nodular lesions in the lower legs, consistent with erythema nodosum. So this gentleman's past history, he had of genital ulcers and mouth ulcers, and he also complained of really bad headache, and episodes of eye pain, which included redness and photophobia, which suggested uveitis. There was ocular involvement in his development in the previous few years prior to admission. And there was also a positive pathogy test, which was noted during physical examination. So this case, it illustrates the classic mucocutaneous and ocular features of Behçet's disease, which are often the initial presentation of the illness. So we'll talk a bit about the neurological manifestation. So there is CNS involvement in 5 to 10% of the cases. The patient's symptoms progressed to include neurological complaints, and he also reported difficulty of balance and coordination. He had tests done, which we'll talk about later on, and he also had cerebrospinal fluid analysis, which showed a high amount of protein in his cell counts. So this progression, it highlights the benign initial symptoms that can evolve into severe symptoms. So other clinical manifestations, there's musculoskeletal, which shows history of oligoarthritis affecting his knees and ankles, affecting the spine and sacroiliac joints, which also helps it differentiate from other conditions. There's vascular aspect, as we mentioned, arteritis, which can cause other symptoms such as aneurysms. There's gastrointestinal, such as mucosal ulcers in the intestines, and cardiac, which this patient had an echo for and was found to have features of pericarditis. So diagnosis and management. So we'd look at diagnosing, looking at the clinical symptoms, etc. We'd get the MDT involvement in this. So the neurologist, the rheumatologist, and the gastroenterologist, along with the cardiologist, were involved in this. The management includes corticosteroids, reducing the inflammation by the use of immunosuppressants, biological therapy, NSAIDs, and pain relief. The initial management was to give a disease-modifying drug such as azathioprine for this patient, and adding the use of infliximab, which is a biologic that can reduce his inflammatory markers. And alongside this, there's the systemic management, such as benzidamine mouthwash that could reduce the symptoms of his oral ulcers. So brain imaging, we looked at the MRI. So we did an MRI scan of this gentleman, which was found to have hyperintensity on the T2 weighted coronal view, which you can see on the image on the right, which had some signs of inflammatory changes there. It helps distinguish the involvement of CNS in Behçet's disease and the extent and location of the disease, as this chap had cerebellar and pyramidal deficits alongside this. Another CT scan showed that there was some sort of thrombosis in this gentleman, which may overlap with other conditions such as multiple sclerosis, thromboembolic stroke, meningoencephalitis, and reversible cerebral vasoconstriction syndrome. So that's why diagnosing this condition, it can be challenging, as there are many subsectors that it can fall down to. So the involvement of the CNS falls into parenchymal and non-parenchymal. So parenchymal subtype is common, where symptoms result from involvement of the brain and the spine and the brainstem, whereas the non-parenchymal type includes conditions such as cerebral venous sinus thrombosis and the involvement of the arteries. So we'll look at the follow-up plan that we had with this 17-year-old male. So the primary goal was to ensure that he did a follow-up and monitor the disease activity, preventing relapse, and ensure that there's management of the long-term complications, as he kept on getting admitted with the same symptoms. So regular clinical monitoring was important in terms of getting the neurologist involved, the rheumatologist, and the cardiologist. And MRIs was important to have follow-up MRIs just to see if there is any increase in the inflammation or if there are further thromboembolic lesions there. And it's important to adhere to the treatment to ensure that the patient is aware of any side effects, etc., of any medication that he's in on, including biological therapy or immunomodulators, etc. Long-term management, same thing again. In terms of side effects, the patient should be aware of any side effects or any blood tests that you should be having prior and during treatment. So just a quick summary and conclusion. So this case shows a clinical picture of Behçet's disease from its early oral symptoms, mucocutaneous ocular symptoms, going down to more severe and having MRIs, etc., and diagnosing Neuro-Behçet's. The progression of the symptoms highlights that if there is raised suspicion, then this should come into play that it could be Neuro-Behçet. And early diagnosis and MDT involvement is important as long as the pharmacological treatment is there, which is crucial for managing the chronic condition and improving patient outcomes. So thank you for listening. This is our case-based study. I've put the link there. If any of you guys want to reach out to me, then you guys can. And if it interests you to have a read of our article, then by all means. And I hope you enjoyed this. And if there's any questions, I'm more than happy to take them on board.
Thank you, sir, for your presentation. Delegates and session may ask questions related to the topic.